Good evening and welcome to another edition of What Your Doctor's Not Telling You. I'm Dr. Mollie James. I am joined by the beautiful Sara Taylor, the physician's assistant extraordinaire in our office in Chesterfield. So glad you came tonight. This is going to be an exciting look at hormones, the three biggest mistakes that are made in hormones for women and treating those. Before we get to that, we have some breaking news that I want to share with you. All right, here we go.
Exemption. Vaccinations for hepatitis B, COVID-19, and influenza, among others, are no longer recommended for all children. In addition, this executive order directs the Attorney General to advance legal challenges against states that violate children's rights to religious or medical vaccination exemptions for the exemption. Vaccinations for hepatitis.
So put a heart in the chat if that affects you personally, your family, if you have somebody impacted by that. He actually went on to say that we have evidence that vaccines cause autism. And I need all of you to pay attention because everybody who fights against this is on the payroll for Big Pharma. Every single one of them, because no reasonable doctor who provides informed consent would ever think this is a bad idea. Not one. So you still have the option to give the density if you think that's what's best for your kids. But they actually took influenza, hepatitis B, and Sara, there was one other one. There's three. COVID's off the schedule completely. So it's about time. COVID should have never been on the schedule for kids. But we wanted to start with that late breaking info because it maybe affects you, kids, grandkids. I'm actually opposed to vaccine exemptions because you shouldn't need them. You should have the ability to say no. We should have the right to give you informed consent and recommend against something if we believe it's going to cause you harm. There actually was another piece of information alongside this. There are a couple of federal judges that sided with Brian Tyson and Pierre Corey that California cannot gag their doctors to give informed consent. So California said you can't tell your patients anything different than what the state says is the law. And the federal judges have now said California state law cannot do that. So that's another big win. I think it was AB 2098. It's been a minute since I looked that up, though. They were actually targeting doctors who were giving informed consent, recommending against, offering vaccine exemptions. They track them in that state. So California is one of the states. We're a little bit more limited on who we can help in California, even back in the COVID era, because of the restrictions they put in place. So just wanted to update you on the good information, good news coming out of the White House on vaccine policy. Before we go on to the main topic, are there any questions on that? Any discussion points that you would like to tackle before we move on to the main event? Yes, super scary that pharma controls all of it. How can it be changed? Actually, along those lines, if you look at the new mRNA vaccine for influenza and go ahead and put us on an early no list, we will not recommend not be any part of that. People died in the trials and it sheds. So this is a terrible idea. The mRNA flu shot is a terrible idea. If you look at the timing of Tracy Hoig, Marty Makary, and Vinay Prasad, they were removed from the FDA and they refused to review this vaccine, and now it's approved. So if that tells you anything about what's going on at the FDA, you should be very concerned. That needs to be disbanded. Can we do anything to get the damaging effects of the COVID vaccine out of the children? Sara, do you want to take that one?
That's a tough question. People don't like the answer. That vaccine, unfortunately, is with you for life. It is an mRNA vaccine. It goes into the body and it replicates and it stays in every organ, every cell of your body. What we can do is mitigate the effects of the spike protein and the damage that is caused by that. And there's a lot of ways that we can do that. And especially kids, they have higher metabolism, they have higher cell proliferation. So good outcomes with that. But unfortunately, no, anybody who took the shot, anybody who was given the shot, unfortunately has that shot for the rest of their life.
Yeah. Which is why we have heavily advocated against from day one for children. Day one, we've always said that's a bad idea. That's why censorship was such a bad thing, right? Because it silenced us. It took literally deleted my Twitter account. I'm up to 175,000 followers. So if you're one of them, thank you very much. It took us off of Meta Facebook, Instagram, like
Google,
absolutely.
everything.
Yeah, we lost our Google My Business for our stance, so people couldn't even find us as a clinic. We've been on the right side of this argument from the very beginning. So we appreciate you being here and supporting us. We will continue to be truthful with you, what's good, what's bad, whether you like the advice or not. We're going to be honest. I wish they would get this out to the liberal public. The problem is, I think there's a quote out there, and I'm going to misquote it. It's easier to be lied to than to convince somebody that they've been lied to. So unfortunately, this is a lesson people are learning the very, very hard way when they're abandoned. There were a lot of liberal people who put their children in the studies and then got absolutely abandoned and gaslit by the medical system. We hate that. I'm hoping that some of the diaries of Fauci that are coming out shed some light on this. I don't know who would trust somebody who takes the fifth 111 times in front of the Senate when he was the face, the direction, the science that we were all supposed to follow for 5 years. We hate that for you. One last piece on this, and then let's move on because we have a lot to cover tonight. I'm also against the scammy COVID spike protein detoxes. So let it go on record. Those are bogus. They are commercial products. They are not factual. They don't work. We struggle to bring those levels down, and we've been doing this since the very beginning, since 2021 when we left the ICU and 2022 when Sara joined us. We've been trying to alleviate that. Some patients, it's easier than others. The only thing that we found that really can remove it, it doesn't remove the production, but it removes the actual spike, we think is EBU, and that's based on studies. So actually, some of the detox formulas can be harmful because they break up the spike protein into more inflammatory proteins in the body. That's based on data that was presented from a GI researcher at the Ozone Conference last year. So I just want to put that out there too. There's some reasons to use some of the specific things, but all in all, there's no such thing as a COVID detox, and anyone selling you that is selling you malarkey. I think that's the term.
Malarkey.
Malarkey. All right. Hopefully that'll get us some YouTube penalty points. All right. We're going to go on the top 3 mistakes made in treating women's hormones. So you see some men on here. Let me tell you what, this is going to affect men probably more than it even affects women. So thanks for sticking with us. It's important to both, right? We need to address this. So Sara, do you want to kind of kick it off?
Sure. So let's just open up talking about the main stars of the show, the first 3 hormones, estradiol, progesterone, and testosterone. So these all have their places. These all have their rights. It's good to know what each of them do to the body systemically and kind of go through them one by one just to see where they benefit each other and how they all work together to support the body and cellular health. So estradiol, we know, is the proliferator. This helps build and maintain tissue. So not just uterine lining, but collagen, skin, even your joint lubrication, your synovial fluid, all the, if you think of lubrication in the body, however that sounds, this helps control and regulate that. So estradiol is the proliferator. It regulates the temperature thermostat in the brain. This protects your bone health. Speaking of proliferation, it is your vascular health. So the blood vessels, skin, just overall skin, your vaginal and urinary tract. This supports your mood, sleep, and interestingly enough, your memory and cognitive health. Progesterone is the stabilizer. So for estrogen, you have to have progesterone. We can't have an imbalance of these two, or that's where we get into problems. So estrogen causes uterine proliferation and the lining to provide a healthy, stable environment for a fertilized egg. That's where the progesterone would come in if that were to occur. This also has a systemic calming effect. So acts on the GABA receptors in the brain. It supports your sleep and is, interestingly enough, only made after ovulation in the female cycle. And then testosterone. So people miss this in women's health, right? They think that we have 2 hormones. We actually have 3. And this one we call the driver. So this is actually our highest volume sex steroid in women by weight. This is found mainly in muscle. It promotes strength. It helps our bone density. It definitely drives energy, your motivation. And what I mean by that is people that lose their socialization after menopause or perimenopause, your to-do list gets shorter and you just don't care. Your overall self-confidence And then the big one is your libido and arousal. So when those fall off the wagon, that 100% is testosterone in a female. So just to sum it up, estradiol builds, progesterone balances, and testosterone drives. As we age, ovarian output is what declines. The adrenals, the fat tissue, peripheral tissues do keep working, which is why you can have two women in the same stage of ovarian failure with very different symptoms, very different presentations. It gets a little bit murky, and that's what we have to work through with you in order to treat these symptoms and identify them as we move through the process.
And one of the overriding themes tonight is everything is individualized. People come in and they're like, my friend did this and it worked great.
Yeah.
That may work great for you and it may not. So we have to remember it's a little bit trial and error, but it's an educated guess in a lot of ways. And we all have a style to how we do that. I've developed my style. Sara might have a slightly different style. I'm not sure. We're usually pretty on the same page most of the
Pretty
time.
much.
Okay, so mistake number one is not checking labs. One of the things that incites me the most is when a patient requests labs from their doctor, hey, can we check? I think I'm having some hormone issues. And the doctor's like, we're not going to check it because we're not going to do anything about it anyway. Like, why would you pay that person for advice? You asked, I have a problem. I'd like to intervene. And they said, nah. So that's not to me a very educated response to the question. So there's different ways to check labs. So what this mistake looks like is a couple of things. First of all, nothing gets ordered at all. So they just, oops, you can see that. So they just say it's not your hormones, or we're going to do something else, or, you know, they don't even look for other things that it might be. So one of the things when someone tells me they're having hot flashes, what's your blood sugar doing? Because when your blood sugar drops and you're perimenopausal, you can actually experience that. It feels like a hot flash, but it's actually your diet's off and you're throwing your blood sugar all around. And this is the first thing. Nothing gets ordered at all, not even the basics, not even your iron. Maybe that's why you're tired. I think most docs have that covered, but every now and then we catch that. Thyroid's probably one of the biggest ones. And we need to talk about at the end, Sara, how we have to readjust your thyroid if we're taking care of your hormones, because they all play, it's like a big cobweb. And when you start to pull on one side, it pulls everything else and you have to readjust. I had a patient that I started on hormones and said, hey, my libido didn't go up. I hate this. And when I looked, her free T3 was 2.5. We wanted to be over 4. So she needed thyroid replaced, but she bailed and gave up before. We have to work through the process. So important to keep that in mind. And this was a person whose thyroid was fine before we started, like literally fine. And I don't say that very often. So vitamin D deficiency can make you feel like garbage. If any of you have ever had, like in the teens, this is a cause of seasonal affect disorder and things like that. So we need to optimize everything. Sleep apnea can be one of the reasons you're not sleeping at night or you're tired during the day. So again, not only are we going to check your hormones, but what are the other things that might be going on that are contributing to your symptoms? Do you want to take the next one?
Sure. Without doing much investigation, I feel like not taking a good history, doing a good physical exam, looking for those physical symptoms of micronutrient deficiency, thyroid disorder, those kind of things. They just check the box and put you on a standard dose of hormone. Here's your estrogen patch, and here's and some of them use pellets, some of them use creams, but no baseline labs, no symptom check, no start. Here's the ledge I'm ready to jump off. Has anything improved over the next 6 weeks? Anything like that. Then I feel like the people say the hormone was not the problem. This isn't working because the right questions weren't asked and you weren't given the respect you deserve to discuss the symptoms, however trivial or however odd they sound. And let me tell you, perimenopause has some crazy symptoms. So you should be able to talk about all those. It should make sense to the provider. And a lot of times they think you're just literally crazy. So the best one that just comes to my mind right now, and I'm literally experiencing it because I'm needing help, but so I need you to come in and pellet me.
Okay.
My ears are itching like crazy. And that's so funny that people don't understand, but when your ears itch, it's literally your estrogen dropping. And it's just another one of those vasomotor symptoms. And the other one that gets missed a lot are these weird heart palpitations that people start getting. And they think that they're anxiety, or they think that they have a heart problem. They want a Holter monitor. They want all these things done through a cardiologist. Really, it's a lack of hormone circulating in the body. So nothing gets ordered, and then they start hormone therapy blind, and the results are disastrous. And they don't make sense for you. They don't make sense for the next person. But genuinely, because they're not putting the time in to learn this stuff, that's all they're going to do. Care without information and treating you without ruling other things out, as Dr. James said. This has a multifactorial implication. So a lot of this can be supported with optimizing your thyroid, optimizing your micronutrients. Are you sleeping well? Sex hormones, believe it or not, are only made during the sleep cycle. So not during the day, not when we're up running around using all our cortisol and our energy. They're made during restful quality sleep. And how many people are walking around not getting that? We need to do the whole picture. We need to do the deep dive in order to get the best outcome.
Yeah. And I would say this, I would say menopause is having a moment right now. This
Sure.
has broken through the sound barrier and people are starting to talk about it. Maybe it's just my feed, but we're starting to talk about doctors aren't trained on this when they come out of residency. No one talks about it. Maybe they have one tool in their armamentarium. But, and gentlemen, I'm sorry, everything is perimenopause unless it's menopause. So every symptom out there, the wild and
100%.
crazy ride, it's perimenopause. Yeah. We're not going to get into it tonight, but also when you look at testing, there are different ways to test. And sometimes we use a blood test. I don't prefer saliva testing for this, only for cortisol. Sometimes we're going to do urine testing to look at the downstream metabolites. So there's different ways to test it also, and we need to make sure we're using a valid method for doing that. Again, I'm not a fan of the saliva testing at all, not the way I was trained. Anyway, so a complete workup, again, is going to be, and a lot of these apply to men too. Here's your sex hormones. So estradiol, progesterone, testosterone. So a lot of testosterone is bound to protein in the body, so your body can't actually use it. So the free testosterone, I'm trying to think of an analogy. Imagine most of it is stuck to a big bubble, and only the little molecules that are running free can be used. So if any of you are on DIM or recognize the name DIM, DIM actually increases the amount of free testosterone that is circulating. DHEA is your precursor. Sex hormone binding globulin, that's that bubble that it sticks to that can swallow it up. And that gets into women's birth control pills, increases the sex hormone binding globulin and really messes with people. FSH and LH are what I consider the menopause indicators. When they go up and stay up, that means that they're trying to stimulate something that's not happening. So, and the day we check the hormones is important in women who are still having any kind of cycle. So thyroid, we have a whole talk on this, so I won't belabor this one. Iron and blood count are going to be important to check. The metabolic picture we've talked about ad nauseum. All of these are on our panels. The basics on nutrients and inflammation, the cardiac screens. Of course, we do an advanced lipid panel. Mammography is plus minus. We can get into that a little bit. We probably do need to have some type of screening that is systematic because that we can let go. If you're going to be on hormones, and we're not going to get too much into this tonight, but hormones and cancer, we probably do need to be evaluating risk on that. Bone density test. If you haven't had a DEXA scan and you're over 50, we need to do one at least probably every 2 years. Yeah. All right. So what labs can and cannot tell you? So what they do well is they tell you where we need to look, right? I tell people sometimes, usually I can tell, and Sara can too, based on what you tell us, what we're dealing with. Sometimes somebody has these complicated things and I'm like, I just need to figure out what bucket are we in? Are we autoimmune? Are we hormones? Is it gut or metabolic issue? Let's figure out what bucket. Then we can figure out the treatment if it's real confusing or multi-symptom or I've been this way for 12 years. We got to figure that out first. So the labs will help us do that. We can establish a baseline, right? We always need to know where we start so that if we're going to institute treatment, how do we troubleshoot along the way? What if we overshoot? What if we undershoot? How do we know if we don't know where we started from? Confirm absorption. So it'll let us know, we can talk about the different modes and how we deliver this, but knowing, is your gut absorbing anything? Is it going through your skin? Is there a reason it's not? I've actually had pellets in the past where the level didn't budge and sometimes it can scar in where it can't get absorbed, like literally once in 10 years, but it can happen. Premature ovarian insufficiency. So if a woman's under 45 and having symptoms, we need to diagnose that early. Things like anti-Mullerian hormone and things like that. Map the metabolic and cardiovascular picture that drives the long-term risk. So we're going to get into this a little bit more on a future slide, but they told women, hey, if you take these, you're going to get cancer. And so women dropped their hormones, doctors quit prescribing them, and what happened? 30% increase in cardiovascular, so stroke and heart attack deaths. So we just traded one low risk problem for a higher risk problem. Sarah, do you want to take the next one?
Yeah. So the labs, again, a good place to start, a good place to create a baseline and to see how we're moving the needle. But what these labs can't always do is diagnose you in perimenopause. Perimenopause, the ovaries are still working. They're just not optimally working. Much trickier than postmenopause. So postmenopausal, we're not dealing with the fluctuation of the hormones. The ovaries are done, right? They've burnt out, they've ran out of fuel. They're not, even no matter what you do, you're not going to be able to re-stimulate your hormones. So they cannot diagnose perimenopause. There's no lab value that can. We do see this still necessary to grab labs, even if we're dealing with perimenopause, just again to establish that baseline and rule out other things. They cannot define low testosterone in women. So again, these lab values, they don't have a normal, they don't have a high, they don't have anything except what the lab value tells you from the lab company. Some women, believe it or not, feel better with a testosterone 300 or plus. And they're not growing hair. They're still cycling. We have a couple young females that their testosterone is much higher than some men their age, and they're still very feminine. They still cycle, they look feminine, they don't grow facial hair or anything. They just use up that much testosterone. So the labs cannot override your symptoms. So what that means is if you come to us and you are struggling and you can't quite put a name to it, you can't quite describe what's going on. If your labs look normal, that does not negate how you are feeling and the symptoms that you're having. So we have to, again, look at the whole picture, listen, and go from there. Oh, go ahead.
Keep going.
They do, however, exclude out risk factors and other causes. So they're very important. But again, it's the whole thing. It's the labs, the conversation, and then slowly moving the needle to get where we need to as we go.
Normal testosterone levels in women are somewhere between 10 and 40. So we routinely treat to usually over 100 and then wherever you feel the best. But there was a study done where they took a patient, they did pellets, and like a week later, they did 5 lab draws during the day, and all 5 of those were totally different. So again, we're going to use those labs to guide us, but they're just a guide, kind of like thyroid. It's just a guide. It is not, it's high, so we need to panic. Okay. And testing is not a one and done. So we're going to start with that baseline. And then once we start treatment between week 6 and 12, we need to check in because everybody is going to respond differently. And my theory when I start treatment for hormones, fresh, I'm going to start low and go slow. Sarah, how about you?
Same. You don't want to shock the system. And it also depends on where they are in their ovarian age. If they started hormone replacement later in life, all those things. So yeah, low and slow is the way to go.
Yeah. Where we get the hair loss, if we jack the testosterone, if we start with a high dose because you really need it, that's when you get hair loss. That's when you get the side effects. So you want to go low, let your body adjust, and then we can sneak it up over time. So week 6 to 12. It's also important to note we'll talk about the types again here, how we replace coming up. Estrogen and testosterone can be metabolized at different rates. So we might vary your dose of pellets each time. Every now and then you have to drop the estrogen dose if it starts to accumulate. I don't do labs before each pellet or every set frequency with testosterone. If you're dialed in and feeling good and you can determine, then we're going to do that maybe a couple of times a year. If we're having problems and we need to troubleshoot or you're not sure, like you feel bad, we're not just going to keep throwing testosterone at you. We're going to check a level and see what else might be going on instead of just blaming it on that. So in some states, the every 6 month requirement, because testosterone is controlled, you actually have to see a person in the office in person every 6 months. So even if we're prescribing injectables, so keep that in mind. If you're not our patient and somebody's doing that, you do need to have that face to face every 6. Again, start low and go slow is the key, the secret to the success of this. Yeah. All right. So this is the part nobody talks about, and this is where your standard doctors are going to get it wrong. So the body just doesn't have hormones or not have hormones. So we build hormones, they interact with our cells, they utilize the hormones, and then they detox the hormones or eliminate the hormones. So at each step in that process, something can go wrong. And especially in cancer patients, is the obvious excuse, right? So I think of hormones as you're standing on a beach on a river and the water's flowing by you, right? And it's going to go right on past you. So that's hormones coming into your body and leaving your body. The oncologists block the river. They dam the river so you don't get anything. You're standing on a dry beach. We like to let the water flow, but make sure it doesn't dam up on this side and flood you. So that's my analogy for how I do hormones. I'm cautious to do it if, say, the liver is taxed out a little bit. Say you drink a little too much and your liver, you have a fatty liver. You're not going to process and metabolize these the same way the next person is. If you're constipated, the worst thing we can have is somebody with a high beta glucuronidase that we check on your stool test and be constipated, because that stool is going to sit there. Your body's going to reabsorb those estrogens and you can have estrogen toxicity or estrogen dominance, if you will. So we want to look at how we neutralize, how do we metabolize everything, and then how does it get out of the body through the bile, through the stool. We have to keep those channels open. Anything to add to that?
No, it's just one of the things, like many, you have to support the body or the body will work against you. Again, the ovaries have an expiration date. And when you're adding hormones into the cellular level, again, you want to make sure that they're being properly dosed, utilized, and channeled out the right pathways so that we're not causing any harm.
Yeah. The one thing I do want to mention, I didn't go into it in detail. If you have a lot of fat, adipose tissue is the politically correct way to say that, whether you're male or female, you are going to have increased aromatase, so increased transition from testosterone to estrogens. So the women are going to be a little bit more masculine appearing. The black hairs on the chin, hirsutism. Sex hormone binding globulin can be a little bit lower. This is why when we start to lose our fat, it can overtax the liver because the body is freeing up anything that's been reserved. Like estrone is one of the types of estrogen. We didn't talk about it. That gets freed up when you start to burn through fat. So we have to really support the body through detox on a body composition or weight loss plan because of that. You gonna take this one?
Yeah, so this just comes down to you guys being able to advocate for yourselves, whether it's taking a vaccine or asking for some better information. Asking a provider to run labs should be standard. You should be able to ask a provider to run labs, including anything that you want, and they should be able to order that for you. So can we run a full panel of labs? Let's check your thyroid. Let's check your ferritin that affects your thyroid. Let's check your insulin, not just my hormones. And just as Dr. James had said, is your body making hormones, but you're storing them and you're not able to use them? Is that the problem? Are you not able to make hormones because your thyroid's not functioning? We need to have a baseline. We need to know why the body is struggling at the time that you're presenting. We need to keep an eye on these. You need to ask what the treatment looks like. When we recheck things, when should you see improvement? How did they come up with your dose and your specific protocol? And then, of course, you want a copy of this. You want to be able to discuss these values with your provider openly and honestly. And for me, somebody who can't have that conversation with you literally tells me they're uneducated. They don't want to have this debate with you because they haven't taught themselves the best way to do this and the best way to decide these things for you with the best interest of the patient. I personally had to really look into hormones when I started doing them at the James Clinic because, again, you hear all the woohoo, they cause cancer, they cause blood clots. And I never want to harm a patient. I never want to harm anybody. So it took a very deep dive for me to have these conversations and to actually really jump into hormone replacement with confidence and point my moral compass in the best interest of the patient. And I can tell you, after the research, looking not just in the US, but in countries that do hormone replacement, that provide hormone replacement. In Europe, you can get estrogen over the counter. You can buy your own estrogen. So in these countries where this is more supported and has better data, the evidence is there. You just have to take the time and learn it and look into it to be able to provide the best care.
Yes. And to me, this last one is where most standard medicine fails. You go in, you tell them your problem. Like that's the start of the conversation. The real, I call it the money. People make fun of me. Like the real, what you want is in the interpretation of the labs.
Sure.
That's the most important part. So the fact that they don't call you back in to review the labs specifically and tell you, here's what I found and here's what we're going to do about it, or here's your options, failure of standard medicine. And some of it is they don't know, they're not taught to do that. I actually started doing it just so I didn't miss anything because we look at hundreds and thousands of labs a day. The chance I'm going to miss something at the bottom of a page that I didn't scroll or that I missed, I'm going to catch it if I sit with you and say, here's your exact labs. Oh, by the way, your liver enzymes are crazy high. We need to do something about that. So I actually did it so that I would never miss anything. And it's really the most important part of what we do, in my opinion. The fact that I would never go to a clinic that didn't do that. Sit down and explain to me what this stuff means. Ooh, missing Perry. Okay. So, are there any, oh, what's it called? The TV show with Beth. Yellowstone. Are there any Yellowstone
Oh,
fans on here? Give me a thumbs up if you're a Yellowstone fan. I got one. Does anybody else watch this show?
2,
A few
3.
of you. Okay, I figured. You're all looking for your thumbs up button. So remember when she says, I'm not worried about the tornado because I am the tornado? That is like perimenopause. It is like the Tasmanian devil and a tornado and all of that wrapped into one. So, do you want to take it?
Yeah, so I think perimenopause is easier to understand once it hits you, maybe, or once you've experienced it. I heard the reference once, haha, what would happen to a man at 45 if you castrated him? If it just no longer had testosterone? And the truth of the matter is, if that were to happen, they would lose their physical strength, they would lose their cognitive function, they would lose their motivation to protect and provide for us. They would totally be a completely different person. But because they're male, the gonads actually continue to produce testosterone and they're able to regenerate sperm through their entire life cycle. So that never happens to a man. It does lower, but it doesn't stop. It doesn't stop.
It doesn't stop. You're right.
Stops. And the period before it stops, where the labs look normal and maybe you're still having your cycles, but they're changing. Before the ovarian failure is the roller coaster. The ovarian failure is what it is. We just replace and we get you to where you're comfortable, but the perimenopause is something. So again, the symptoms are long. It can last anywhere from 2 years to 10 years. It's erratic. You can feel fine and then you can feel terrible. These labs are used to guide us, but not to treat, for sure. Menopause looks a little bit different. So this is when the ovaries no longer function. This is when the loop changes from the stimulation to the response to the stimulation and no response. And then we call menopause 12 months without a period. I feel like that's changing because we're treating perimenopause a little bit different now. So it may extend your cycles as we replace your hormones earlier, which the data suggests is the most protective way to do it. So menopause, I don't normally say it has to be a 12-month period without a cycle, but roughly 12 months without a cycle. And then postmenopause is everything after that. The big one with perimenopause is knowing the order that the hormones transition in. So we'll get into that later. Menopause is just looking back, and then The postmenopausal, the big thing I think we need to focus on is the vaginal health and the urogenital health that plagues us as we age. So here we go. The order in which things fall. The first hormone to depreciate in perimenopause, menopause is progesterone. Testosterone follows, and then lastly, estrogen or estradiol. This is when you lose your cycle. But before you ever lose your cycle, you're losing other hormones. You can have irregular cycles. You can have regular cycles that went from 28 days to 30 days to 24 days, long before they ever stop. Estrogen can still fully be present with this. You're just losing your progesterone. Then your testosterone starts to fall after that, and then your estrogen. So testosterone can taper as early as your 30s, especially the busy working mom, right? We use up all the sex hormone binding globulin. We're running at 100 miles an hour. We're doing all the things. So we're burning through that much faster than ever before. So that one might be more of a cliff dive than a gradual taper. These are just things that we have to know as we're treating you, as these symptoms are developing, and as we have this conversation with you.
Yeah. And one of the things, again, why I don't call us functional medicine is because I disagree with what they talk about on some levels, right? They just say eat enough vegetables that your body itself sometimes, right? Like in hormones, they don't believe
Take
in
some wild yam root. It'll be
Yeah.
fine.
Yes. But when we look at the it's called the HPA axis, right? So stress in the brain from the adrenal or from the pituitary affects the thyroid, affects the sex hormones. So they say treat the stress first and it'll affect downstream. If you're about to lose your job because you don't feel like yourself and you're irritable and you're post peri whatever menopause, you don't have time. You can't just say, oh, I'm going to stop having stress right now because it's bad for my health, right? So that's where I don't fully align with functional medicine. Yeah, that's a great thing to do to start and get to the root cause. Some of us just need relief. We need treatment and we need results. Then we can work backwards and hit it from the root cause and come back forward.
And you have to get to a place where your body feels balanced a little bit, because that little period of time where things start to really fall apart can be very emotional for the female, again, the
And
mom, the
everybody.
wife, and everybody else that's in the path of the tornado.
Yes. There was something else I was going to mention up here. Oh, one of the things when we look at treating perimenopause that I think is so important is we teach women what symptoms, what is deficiency of each of the hormones look like, and how can you treat it yourself. So we don't say, here's your prescription, go do it.
Yeah.
We say, here's your tools. So when you have this, try this one. And when this is happening, do this one. Then they can modulate and have some sense of control in it and let us know what's working for them with guidance, right? So why perimenopause gets missed, it's the you're too young. I don't know if any of you have gone to the doctor and they're like, well, you look great. You're young and healthy. And you're like, I feel terrible on the inside though. The you're too young is one of the things. Your labs are normal, right? Again, when you have 7 minutes to check off a visit, check. I don't see any highs or lows, so you're good to go. You can have heavy bleeding at the same time you have something else. You can have an excess of estrogens from something else while your progesterone is low. It probably will go together. So we don't need an SSRI. We don't need this individual. That's the first, somebody actually posted this in a social media or somewhere that here's the board exam for OBGYN. And it was somebody who was having this problem and the first line treatment was an SSRI. So bad call. We have better ways to treat that. Or it gets treated as menopause and they get started on estrogen too soon, creating an estrogen dominance problem, breast tenderness, vaginal bleeding, cramping, things like that, and overtaxing the liver because we're not replacing the right thing at the right time for the right patient. Okay, speaking of teaching people how to determine. So low progesterone, these are going to be heavier, longer periods or shorter cycles, spotting, cramping, clotting, things like that, right? So you're starting to see as you're dropping progesterone, you're starting to see an estrogen dominance pattern. So that's where adding progesterone as one of the first lines is going to be helpful. This one's interesting, the waking at 2 to 4 a.m. I've actually read some wild theories that people used to get up at 2 to 4 in the morning because they were in that gamma wave of sleep, and that would be intimate time, that would be like thinking time, that's when authors would write books. So we actually maybe were made to wake up between 2 and 4 a.m. and sleep a longer night overall and have 2 hours of productivity in the middle. And the theory is corporate America ruined that for us by saying you need 8 hours of sleep and you need to be at work at 9 a.m. So just an interesting counter theory there. You can take that or leave it. So trouble falling asleep, trouble staying asleep. Oh, the other thing I've heard is if you're waking at 3 a.m., it's because somebody's wishing you bad things. So I don't know about that, but I have yet to get a voodoo doll to correct that one. Feeling wired, so unable to calm and relax and unwind for the day. Irritability. So a lot of women come in and say, I don't feel like myself. I'm irrationally overreacting to these things. I don't want to do that. I don't know why I'm doing that, but my kid did this the other day and normally I'm just like, "Hey dude, don't do that." And I just went off. So those are some flags that we're looking at. Worsening periods, again, getting tearful in the middle, and then again, breast tenderness. So these are the estrogen heavy things. Fluid retention, bloating, migraines. So these are cyclical migraines, weight gain around the middle. So you're in build with no control, right? Sara, do you want to add?
This is where I think people that are in tune to their bodies start to notice things, but they can't put words to it because it just was not heavily discussed. But these are successful women that have, you know, their stuff together, right? Maybe even a little type A, maybe they're balancing life, they're balancing the kid schedule, they're balancing marriage, corporate, whatever. And this just starts to fall apart. You've done this for 20 years in your sleep and you're good at it. And all of a sudden things are just falling off the wagon. It is a terrible feeling. Somebody who had never had anxiety, never had mental health, never had anything like that before is sincerely struggling. And they again, they have trouble verbalizing this because it's not something they dealt with before. They're dealing with it now. It's coming before their period. And in their head, they're still getting a cycle. So there's no way this could be their hormones. But I hope these open discussions, educating people, all these things will help us treat people better, treat people and intervene faster and negate some of these downstream effects.
We're
This
coming to
one's
the we're
this
gonna
one's easier.
yeah, we're coming to the top of the hour, so we're gonna kind of pick up the pace here so we can get done. Do you want to take these?
Yeah. So the
Okay.
low estrogen, this is where you start to get the hot flashes, the flushing, the night sweats. These are the heart palpitations. This is where women start to think, oh my gosh, I can't find anything anymore. I can't even remember people's names. I really see people try to seclude themselves at this point, right? They're not as social as they used to be. They're not sleeping well. They're exhausted. They may be getting frozen joints, so joint pain, morning stiffness, dry hair, dry eyes, accelerating bone loss. Sex becomes difficult because the vaginal tissue is dry and it's uncomfortable. They're urinating more often. They're getting up at night to pee when they don't really have to pee. All these things with low estrogen.
Yep. And just a couple additions to that on the brain and mood, when we have people come in that this is the very last thing they tell us, right? We have an entire hour and then they're like, "Hey, I'm really worried about dementia because my mom has it." Right? It's that slip in there. Most important thing, we're talking hormones. So I don't remember the statistics because I was driving when I was listening to a podcast, but I feel like it's 60% better cognitive function or 60% reduction in cognitive decline. One of
Yes.
those two statistics. So we need to replace testosterone, estrogen if you want your brain to function and stay healthy and young as long as possible.
Highly neuroprotective. Highly neuroprotective.
And then on the genitourinary side of it, so the labia minora starts to go away, just atrophies and
Atrophy.
dies, goes away. And this is so important. Treating women with estradiol actually has a mortality benefit. Now, we can get into an entire conversation of should we let women in nursing homes die of UTIs or are we going to sub-select for them dying of something more horrible? That's a whole different conversation, but it has mortality benefit. That's how strong this recommendation is. And there literally are only one or two contraindications. So if you've had breast cancer, hormone positive breast cancer, if you've had ovarian cancer, cervical cancer, you are still a candidate for vaginal estrogen, almost universally accepted. And if your doctor isn't in the know, let them go. So not explaining risk correctly, getting to that point. So it's the Women's Health Initiative that came out in the, was it 1990s? So about 30 years ago now. And the headline was a 24% increase in breast cancer in women who had hormone replacement therapy. So that's what got the headlines, and doctors shut it down. Pharmacies quit carrying it. I actually worked in a pharmacy at this time, and the majority of women were on Prempro. So Premarin, which is conjugated estrogens from pregnant mare urine, and medroxyprogesterone, which is a synthetic. So both natural derived and synthetic. They didn't break this out for women receiving bioidentical hormones. And all of the risk lives in the medroxyprogesterone arm. So women who were taking Provera are the ones who had an increased risk of cancer. So nobody teased that out. They just said all comers thrown in one bucket with no separation. We do know that oral estrogen raises clot and stroke risk a little bit. It's that first pass effect through the liver. So you can take an oral estradiol. I don't recommend it. I'm usually putting people on something topical or pellets, which is topical, absorbed through the tissues. And then they didn't talk about benefits at all. Fracture reduction, colorectal cancer, inflammatory bowel disease, cognition, strokes, heart attacks, all of those things were totally left out. And the estrogen alone, fewer breast cancers in the estrogen alone arm. And the women with those breast cancers tended to have better outcomes, less recurrence. The recurrence wasn't as aggressive. So across the board, they pretty much got it wrong. So they applied it incorrectly. So in the last year, we've seen a lot. We've had a lot of these menopause activist doctors now. Kelly Casperson's one of my favorites. She's a urologist. You have Mary Claire Haver, one of them. There's a group of them. There's a Rhonda Patrick, I believe, is an orthopedist that's looking at women with osteoporosis and operating on them. So you've got a group of women. I'd like to think we're part of that. We're just a little more quiet. They got the box warnings off of vaginal estradiol. They're trying to get testosterone to be removed from a controlled substance. I don't know why it is controlled. It creates a lot of havoc behind the scenes for us. It shouldn't be. All the other hormones are uncontrolled. So the updated labeling emphasizes the timing. So the main risk gap is for women who are 10 years or more postmenopausal and start it fresh that long after. There's a little bump in increase in CV right up front, and then it flattens out and reduces back down. So I still think it's worth it. One of the most common questions we get. And the endometrial cancer. So if a woman has a uterus, we never offer systemic estrogen without the balancing test progesterone. Can't do it, not an option for you. And you're going to find this out if you try it. I've had a few women that forget to go get their progesterone, and they bleed and they call back in, and that makes everyone unhappy. So progesterone with estrogen all the time if you have a uterus. I think it's good practice to do it even if you don't have a uterus, just good practice. So there's still risk. It's not zero. So, but we have to balance the risk, and we have to look at cancer is not the only thing. And these other things are actually the number one killer of women. So what are we getting for withholding that? You want to take this one?
So again, just the risk and absolute numbers were never declared the way they should have been. They're saying eight positive additional breast cancers. So with oral, not transdermal, not pellets, but oral estrogen, plus a synthetic progestin, which we talked about is not what we use. After about 5 years, fewer than one extra case per 1,000 women per year. So even with the bad hormones, it wasn't that great. We did know that the blood clots increased with the oral estrogen, the first pass liver metabolism, which we avoid now knowing that. And then in the oral formulas, we also had an increased risk of strokes. But there were fewer hip fractures, fewer colorectal cancers, and fewer breast cancers. So before the jab and before all these super cancers, think about when breast cancer was diagnosed, right? It was always elderly women. It was always women in their 60s and 70s. They had been postmenopausal for years. So their body had been without estrogen for years when they developed the cancer. So I find, just logistically thinking about that, I find that interesting that they said that hormone replacement and estrogen increases cancer, but most cancers were identified at one time in an elderly population that had no systemic estrogen.
Same with men and prostate cancer. If
Absolutely.
testosterone drives prostate cancer, how come it's not happening in 18-year-olds?
Right. So again, the timing and the route matters. So again, starting as soon as possible. We know now that this is being studied and talked about, that starting sooner is better. That doesn't say you can't start hormones later in life. I do it all the time. It's the low and slow, and it's just an awakening in the body. So starting before age 60 is optimal within 10 years of the final period. This is with bioidentical hormones. And the risks are, they say that 15 or 20 years postmenopausal, your blood vessels have already established a plaque or disease. And the same estrogen offers no cardiovascular protection, and it may increase risk. Again, that's where the route and the dose come into play. So transdermal versus oral, etc. So sometimes we have to tell you no. Sometimes we have to look at risk versus benefit. We have to have those deep conversations. If you're coming in with a cancer history and you're young and it was a hormone positive cancer, that is a conversation we are totally willing to have with you. We're going to show you what we know. We've looked at the studies in Europe treating cancer patients post remission with hormones. We've looked at all of this and we're willing to have that conversation with you. We're willing to have the conversation about hormone deprivation, all these things. And the same goes with active disease. So if you're prone to blood clots, if you have active liver disease, if you're still trying to conceive, we have to have all the information. We have to have these conversations.
Yep. Migraine is a good place to say yes, actually. That can help. Seizures is not a good place. Estrogen can lower the seizure threshold. Those patients, we're going to consider it. I'm going to skip some of these. Endometriosis is usually hormone driven. So if you're having undiagnosed vaginal bleeding, anything like that, we have to work that up first. And this, I would disagree. They're going to say no. We're going to say yes. I can arm wrestle them, but it's easier just to take it and feel good. So the three mistakes, again, not checking the labs, not checking any labs or not checking the labs, not understanding the perimenopause, and not explaining risk correctly are the three big mistakes that we see. So here's how to solve it, and then we'll get to some questions.
So again, we want to measure before we treat. We want to look at the whole picture. So we want to look at the endocrine system. We want to look at the excretory system. We want to look at the detox pathways. And then we want to individualize this. So we want to take your symptoms and match a treatment based on where you are and what's best for you. We want to choose the right route. We want to track progress. And we want to sit down with you and have these conversations. We want to show you what we're trying to accomplish and see if that is what is making you feel better, or do we need to adjust some more?
Yeah. And as we have more and more women diagnosed with breast cancers in the wake of the COVID-19 fiasco, counseling women who are in that age group on hormones and offering those as replacement is probably going to be one of the things that we will be one of the few clinics in the country that do, with a very frank discussion and disclaimers. And we think it's fine, but also you need to be aware of what everyone else thinks, and everyone else is going to tell you if it doesn't go the way we want it to. Okay. We went over that. So if you know someone who's struggling with this, send them in. This is easy day in our world. We can have these conversations. We can get them a plan. We have a variety of different ways that we can treat. We have different options. They're going to be different for every different woman who comes through our door, and we'll combine something that works for you. Cool. So can friends of mine access the webinar on your website? It's on our YouTube channel. So I try to get the replays on there by tomorrow morning. If it doesn't happen tonight, it usually doesn't happen at all. I'm going to be honest with you.
Find something else to do.
I need a producer. What can I say? I need a producer. I need an assistant. I need a producer. Okay. My mom went through premature ovarian failure at 37. They would not do anything for her at the time. Yeah, that sounds about right.
Our moms were warriors. I think back, and now that I have kids of my own, it's like the perfect storm, right? Depending on when you had your family, it's like we're going through perimenopause and menopause, and my kids are like raging testosterone monkeys right now. So it's no wonder you hated each other when you were little. And they didn't give them hormones. And it was these women, they had natural childbirth, they went through menopause, all these things. The one thing I want to say though is I do get some patients in here, and as I'm doing their consultation, I ask them about these things, and they're, oh no, I'm past that. I made it through menopause, no problem. Let's talk about the benefits though now of replacing that hormone, because there are so many physiological benefits to having circulating hormones. We still want to have that conversation with you, even if you've already made it through and toughed it out and gotten your medal.
Yeah. Are the slides included on the YouTube channel? They should be. Yeah.
Yeah.
It should look like just the screen you saw.
Yeah.
Yeah. They are. Yeah, just go to YouTube here. Actually, let me connect the link while you answer the question, Sarah. Is
Yeah.
there
So
an
you
age limit to using hormones? What if you're in your 70s?
happy to have that discussion with you. Happy to have that discussion with you. No, there's not an age limit. Again, I had to really look into these things before I felt comfortable prescribing, pelleting, doing any of these things procedurally, just on my conscience, right? So I never want to hurt somebody. I feel comfortable giving a 70-year-old female hormones. I think you would feel amazing. Husbands, you will love your wife on hormones, especially when the libido comes back, when we're not just dead at 9 o'clock at night, needing to go to bed and want nothing to do with you. There's so many benefits to hormone replacement. The list is long.
I can tell you once a woman has had hormone replacement, there's never a conversation on the budget. There's always room in the budget to have the
Absolutely.
hormones done.
Absolutely.
So we do offer different kinds. So there's kinds you can pick up at the pharmacy. There's progesterone is always a pill. So that's always a prescription at the pharmacy. Estrogen, I don't like the pills. Sarah,
I won't do them. I won't do
yeah,
oral estrogen.
yeah, I don't really either. Patches, pellets, or the vaginal cream are the three routes I prefer. The vaginal cream does not treat systemically, so just throw that out there. And then testosterone, I strongly prefer pellets. Sarah?
So it depends. It depends. I'm actually even looking into the estradiol injections from Neil. But so testosterone injections are fun if you're looking for different things. So again, happy to have that conversation. I think it does more for the libido and the benefit of intercourse. So again, happy to have that conversation.
And we do have a couple of women on injectable
Yeah.
testosterone at a microdose.
Yeah, very microdose. Linda says she's 65 and she loves her HRT. Joints are happier for sure. Energy is better. Best decision ever.
Yeah, I think again, we'll just close on this note. One of the biggest mistakes is people think it's sexual. That's
Yes.
how it's been advertised. That's what people buy for, right? In the marketing world, sex sells. So a lot of people are embarrassed to talk about it or like, no, I don't need it. I'm fine. This is your brain. This is your bones. This is your blood vessels. This is your muscles. We know muscle determines longevity. So this is a systemic discussion. This isn't just a sexual discussion. I would say that's really 10 to 15% of even the benefit that you're going to get out of it. So we'll open the discussion with you if you want to discuss it with us. We never push it. I don't know if you guys know this, but we've marked like our pellets are cheaper than anywhere else because you're our concierge patient, so we're looking out for you on that. So it's not worth it for me to put pellets in you if you don't want them. That's never our motivation, but we definitely going to want to encourage you to at least consider it so that your brain and you get all those systemic benefits. I think we answered all the questions. Oh, one more. How about compounded creams?
Sure. So if transdermal is the way you want to go, so if in your head you can't commit to something under the skin, which I'm fine with at the beginning, but I'm telling you, the routine is annoying. So like myself, even though I had done 100 pellets, it's like, oh, I'm going to start with a patch and I'm going to do some testosterone cream. And holy crap, in my life, that is unmanageable for me personally. I was forgetting to put it on, and then you can't touch your husband or your kids if you got the stuff all over you because they could grow boobs, right? So if you have estrogen cream on and your husband, it's just a little bit messy that way. But yes, if you don't want to commit to a pellet, there are hundreds of ways we can get around that to see if your body tolerates it, to see if this is what you were looking for. And then we can always convert. We can work this many ways.
And again, this kind of dovetails into some awkward conversations.
It does.
I was telling somebody this. I'm like, the cream rubs off, and they're like, no, but I put it somewhere it doesn't. And I'm like,
Yes.
Men
Okay.
put testosterone on their scrotum, okay? We can just have that. We know anatomy. We can have that.
Yes.
It's really funny. But women usually put it on their inner thigh. When I train, this is why I don't personally like creams, but it's an option and we'll do it. I won't, but the girls will. They the first commercial is hilarious, right? Because you put it on and then you rinse off the sink and then the sink's got it and then the towels from the sink's got it and everywhere's got it on it. So it's just a mess problem that nobody can touch anything in the bathroom where the person applying testosterone is. It was also a House episode. I don't know if you remember the TV show
Yes.
House. The little daughter was like having all kinds of problems because the dad was giving her a hug and it was rubbing off. They also had a case of a show dog that went bald. The show dog went bald and tens of thousands of dollars to figure out why this very expensive dog lost its hair. Its owner was picking it up and the hormone cream was rubbing off on the dog. So that's just, we're all a victim of our own circumstances and what we heard about. So we're pretty open to trying most routes, but we do have our preferences and biases. Good, great question though. Oh,
Do
two
you
more questions.
pellet non-concierge? Nope. Nope. And the reason for that is very simple. You need a good set of eyes on you, right? I once in 2.5, 3 years have had a bad outcome with a perimenopausal pellet. And I mean, her hair fell out and I felt awful, awful. So if you were to come in and you're not my patient and I pellet you and something bad happens, whose hands in the pot now, right? So we have to have that discussion. We have to do our evaluation in order for us to feel comfortable doing this. So you have to be concierge. Yes.
Yep. And that's just a policy I've established. I want to know who's on our merry-go-round. Who are we taking care of? If it's time for us to pellet you, are you our patient or not? Some people say this is my PCP, but I haven't seen him in 2 years. So then is it really your PCP? If you're in our concierge plan and I want to pick up the phone and call you, my staff's going to pick up the phone or I'm going to pick up the phone and call you. And we know we're in a doctor-patient relationship.
The other thing I want to bring to your attention is go look around. Go look at these hormone replacement clinics. You're talking, so for female pellets, excuse me, female pellets, you're talking $599 to $650 every 3 to 4 months. And for males, it's upwards of $900. Sometimes they actually charge you based on the amount of testosterone replacement in a male. So it can be $900 to $1,500. I'm not going to discuss price over this, but for that kind of money, you could have exceptional James Clinic care 24/7. For
Yeah.
that money, paying for your pellets would get you onto our plan. So use your resources, do better.
Yeah. And those centers don't look at the risk. They don't do all the labs we do. They're not
No.
all, I've seen people not replaced on thyroid properly. And the biggest nightmare of all, let me tell this one and then you hold that thought. I had a patient come in that said, "Hey, we were going to this clinic to get pellets. Can we just come to you and get pellets?" And I'm like, "You can come to me, but I'm not going to guarantee I'm going to do pellets." So the patient came in, his testosterone level was 750. He didn't need pellets. He had Lyme. But since they're a hammer, everything's a nail. And they were going to pellet him because if they didn't have that as a solution, he was no longer their patient. So in our world, we don't have that problem because we're going to look at everything head to toe and we're going to help you regardless. We just have more options on the table. So again, it's a little bit more of an investment probably than piecemeal, but if you start adding in phone calls in between and questions and I need a lab review and some of them require labs every time because they don't have that relationship, it adds up really quickly. And yeah, we think we're a better value across the board. Sorry, go ahead, Sarah.
No, I just had a patient last week come in for a new patient consultation, and believe it or not, she runs a practice of pelleting. So that's what they do. And she's dissatisfied with her care. So she's here because they're not asking the right questions. She's not getting the right results. So
Yes.
good on her for advocating for herself and coming in to have a better evaluation.
And honestly, we're over time. So if you have to go, we understand. To that extent, going somewhere that does the cancer piece of it, I backed way off on hormones when I was going through the integrative cancer piece because I'm like, I don't want to hurt anybody. And I don't think I was hurting anyone, but now I start to question it. 2 or 3 years ago, when I was going through that, we kind of backed down on that for just a minute and we did it, but we didn't advertise, we weren't doing webinars about it. In the integrative medicines, in the integrative cancer space, you've got someone over here saying hormones are bad for everyone all the time and you should never do them. And you have the person over here saying every cancer should be treated with this hormone and they should be balanced out. So even in our little niche of the world, there's debate and discussion. You kind of just have to pick what you want to do, and we'll support you. If you don't want anything to do with hormones, we'll be fine with that. If you want to dive into it, we'll be fine with that too. We're just here to advise. Cool. Very good. We made it through another Monday night. Thank you guys so much for hanging in there with us. We are a little over time. I don't know the topic of next week, so tune in. It'll be exciting, whatever it is. We are in the gut and hormone quarter. I think next week is probably a lot about hormones and cancer. So if you want to know the tie about hormones and cancer, I think we're going to dive deep into that next week. Prostate cancer, breast cancer, things like that. We'll talk about how they're tied together, why we do and don't like certain treatments, and answer all your questions. So thanks a lot. Good night. God bless, and we'll see you next time.